Good morning, and thanks a lot for the introduction. And I would not contradict Roberto and I also say that open surgery is the gold standard in connective tissue disease patients. But if we treat patients with endovascular means, it may work well if we respect certain rules. So this is what we heard about. Open TAA repair is gold standard, but is not very popular amongst our patients, and a lot of patients who have looked it up in the internet come, even if they have connective tissue disease, to ask for alternatives. And another issue, of course, is that the related costs after the operation can be significantly higher compared to what endovascular repair can offer. And the question is whether we can bring those advantages also to our patients with connective tissue disease, which is one of the last resorts of these open surgical procedures. There is also what I learned, there is a dogma which actually not has been really proven, rather than in a few early endovascular series with limited results, that says gas patients, they are generally young and fit and they tolerate open repair very well, but they do not tolerate stent grafts and should therefore not be offered endovascular therapy. And I'm convinced that this is true for what is most frequent in those patients, which is proximal aortic disease and root disease. But my personal experience in my practice is that gas patients frequently are old, have had multiple previous operations, and are quite cardiopulmonary compromised, many of them. And they do not tolerate open repair very well, and they frequently do not want to have open repair. Surprisingly, in the patients that we treated with endo, it has worked quite good in a number of patients. I'm going to show you a few examples. And so that I believe that under certain circumstances they can tolerate it well, and that I'm not alone with this shows this slide from a member of my of the Maastricht clinic, and it shows that in their practice of a certain time, even in this high expertise center, there's a significant mortality, and Michael Jacobs would even quote that this surgery has high risk for mortality and morbidity, but it's done because there's no other option, and that's to be questioned. So the incidences in which we treat gas patients endovascularly is when the diagnosis is unknown at the time of treatment, when it's an urgent thing, or if they are turned down for open surgery, or if we bridge between two replaced segments. There's some early publications about this that had concluded that there's a very high conversion and mortality rate, and therefore it should not be used. In my mind, we shouldn't throw out the baby with the bath here, because there's also some studies like here from Stéphane Holland's group showing that at midterm, at least, there are good results regarding mortality and stroke. And if we look at, for instance, our Arch branch database, this was until 54 cases with good results regarding mortality and stroke, and we looked up the patients that had connective tissue disease or genetic aortic syndrome. Those patients actually did pretty well compared to the others and were not higher in mortality or stroke rate. But that requires to apply certain rules, like that we tend to land and replace the aorta, also in the carotid arteries. This is the group of patients that we treated, which are 30 patients, most with TEVAR, some with EVAR, some hybrids, and some fenestrated and branched. The Marfan patients were 55 years old. Most of them had dissection, and most were treated in an elective setting. And you can see that the proximal landing even was more frequent in native aorta, as was the distal landing, and the mortality was somewhat high, which was mainly in the urgent cases, but also in the hybrid EVAR that had the highest mortality. So just a few examples. This is a typical 45-year-old Marfan patient with a mid-segment that is dilated who received a branched fenestrated TEVAR, even a branch for the segmental artery, did very well after years. This is a patient 4-year post-TEVAR in a Marfan. This is patient 5-year post-TEVAR in native zone 2 in a Marfan patient. Another patient 8 years post-TEVAR in the native aorta. And to come to the end of the talk, we consider endovascular treatment as a first option in all genetic aortic syndrome patients, and we prefer it in cases when we bridge from replaced to replaced aorta and in older comorbid patients. And in my experience, zone 2 appears to be a relatively safe landing zone as long as it's straight, and we don't use bare stent devices. And the oversizing may be adjusted. To conclude, there's no place for dogmas in aortic surgery. Patients with genetic aortic syndromes expect to be offered modern, contemporary, minimally invasive techniques when justifiable, and treatment of gas patients should be centralized to aortic centers that can offer all treatment options. Thank you very much.
Thank you. Thank you.